screened between 3 to 5 years. 3 to 5 years, those who are living with HIV. Meaning that the general population is supposed to be slightly longer. They are the ones who are supposed to be screened 5 to 10 years. So this is the output that we normally get from WHO.
So then we'll jump to the second poll question for the session today, which says the neonatal VIA and HPV screening algorithm includes the neonatal, or rather the national, just a second, allow me to share the poll. All right, so the national VIA and HPV screening algorithm includes, choose one answer. Option A, rescreening women living with HIV every 2 years. B, rescreening HIV uninfected women every 3 years. C, rescreening women post-treatment after 1 year. D, VIA should be done for every HPV positive woman. C, all of the above. I'll read the question once more. The national VIA and HPV screening algorithm includes, and the condition is you need to choose one option. A, rescreening women living with HIV every 2 years. B, rescreening HIV uninfected women every 3 years. C, rescreening women post-treatment after 1 year. D, VIA should be done for every HPV positive woman. C, rather it should be E, all of the above. There was a little bit of a typo on the options there, but you are free to choose whichever C applies. So I'll give it a few seconds to allow for a few more participants to submit their responses. We are currently at 54% of the network that has participated in this poll. And I'll end the poll in the next 5 seconds and share the results. There you have it, network. Clearly, we had 74% of the participants thinking C2 was the correct answer, and that's supposed to be E, was the correct answer, which is all of the above. And then we had a few that sided on option D, saying visual inspection and with acetic acid should be done for every HPV positive woman, and the rest thought A, B, or C were correct. So I'll stop sharing the results and ask Dr. Kamfwa to take us through, and hopefully we'll get to understand what the correct answer is. Dr. Kamfwa.
Thank you so much. Now, if you look at the national guidelines, as we are starting at 25 years old, whether somebody is HIV positive or HIV negative, which is slightly different from what WHO gave us. And we are ending at 59 years old. Now, let's try to come back if we are using HPV DNA. If we are using HPV DNA, the screening interval is supposed to be 5 years in the HIV negative and 3 years in those who are living with HIV positive. But remember, at the outset, I talked about other platforms which can be used for screening. So in a situation where somebody is using VIA, which is visual inspection under acetic acid, or cytology, then the interval is 3 years. So if you look at that algorithm, which we have, it is now trying to bring to our attention when we are using VIA testing. So if somebody is HIV negative, what have we said? They need to be screened after 3 years. But for those who are HIV positive, they require to be screened after 2 years. And in a situation where the VIA comes out positive, then we need to assess, does this person require ablative method? To ablate is essentially just to destroy those cells. We can either use thermocoagulation or cryotherapy. And once we have treated that woman, then the woman just requires to be seen after 1 year. But again, if that VIA is positive and it was not eligible for cryo or for thermo, then the patient requires to undergo excision, which is lip. If we are using DNA, and we said that a woman is living with HIV, AIDS, then we should rescreen after 3 years. But if it's general population, 5 years. And again, what is going to happen is that if we have done HPV and it comes out positive, then we have to do a triage. In this case, we have to put acetic acid and we call it VAT, because this time around we want to treat. And the treatment, of course, is going to be based, either we ablate or we excise. And the post-treatment is going to be after 1 year. In a situation where we are suspecting cancer, then a biopsy has to be done and we have to treat the patient or manage the patient accordingly. Cytology. Cytology is mostly being done in the private sector. So in the private sector, for cytology, for HIV positive to be rescreened every 2 years, negative 3 years. And that's the most important thing. We have been talking about the women living with HIV. Why are we interested in these women? It's essentially the women who are HIV positive, they are 5 to 6 times at risk of developing cervical cancer, 5 to 6 times. Why should they have 5 to 6 times? It's because when they get HPV, it persists in them. At the same time, they have got a high incidence and the prevalence. And these women, when they get the HPV, they get multiple types of high-risk HPV. Let me tell you what used to happen long time ago. People used to fear when they have been diagnosed with HIV. To tell you the truth, if you were to come to Cancer Diseases Hospital, people now fear when they have been diagnosed with cervical cancer. And yet we know cervical cancer is purely a preventable disease. So if it is a preventable disease, that's why we want to focus on our women who are living with HIV, because they are 5 to 6 times at risk.
Dear network, we are going to go through the third poll question for the day, which says, when using the screen and treat approach, treatment provided based on a positive primary screening test alone and do not require sophisticated laboratories, expensive equipment, highly trained doctors. Is it true or is it false? I'll repeat the question. When using the screen and treat approach, treatment is provided based on a positive primary screening test alone and do not require sophisticated laboratories, expensive equipment, highly trained doctors. Is it true or is it false? Now, this is a simple one. We expect 100% participation from the network. And you would agree with me that a number of the participants on the call, dear network, are voting for one of the two options. I will show you the results soon. We have an inclination towards one of the answers, and those that can appreciate, Dr. Kamfwa, you can see that the voting is quite, it's fluctuating. Okay. So I will quickly end the poll for now and share the results. So out of 160 people that took part in the poll, 74% thought A was the correct answer and 26% thought B was the correct answer. Dr. Kamfwa.
Very interesting results that we are getting. Of course, when we are talking about screen and treat, this uses a point of care screening test. And an example of a point of care screening test is VIA. When we put vinegar and we find that the woman has got a lesion, the same time we are going to say, let's excise this lesion or let's ablate the lesion. It can either be done in a multiple visit or it can be done in a single visit. But when we're doing screen and treat, it's primarily based on the primary test. So the primary test, if we are using VIA, once VIA comes positive, then we say we treat. And what are the benefits? If you look at this, VIA, which we are using vinegar, it is not sophisticated, and vinegar is, we can obtain it everywhere, meaning that even the equipment that we use is not expensive. We use the camera, the same Canon camera, and we just magnify the image, maybe sometimes 70 times, and we do not even require highly trained doctors. Our nurses are able to do this. And because we are going to do it during the same time that we have found the lesion is, it means there is a reduction in the lost to follow-up of the patient. At the same time, there is a reduction in time lag for our women to receive the treatment. And ultimately, it's cost-effective. But it has got some limitations in that it lacks diagnostic steps, meaning that the results can even be false positives or we are going to overtreat. What do I mean by this? Because once the results have just come out saying VIA is positive, then we don't know, is it CIN1, CIN2, or CIN3, but we just go on to treat. And sometimes there is this over treatment. So those are some of the limitations. If you look at the picture, it is trying to bring to our attention the VIA screening services. So there is that nurse with a camera, and of course there is that TV in which, on which the image is going to be projected. Next. And the materials that we use, that's why we said it's cost effective. It's the same vinegar that you find in ShopRite or other chain stores. And of course, just the cotton, the gallipot, not very expensive. So let's try to look at the VIA image. If you look at the cervix, it is pink in color because of the squamous cells, which we find on the ectocervix. But the reddish appearance on the cervix, it's the columnar cells. Why is the thing like that? It's because of the blood vessels that we normally see in the underlying stroma. And when we put vinegar on the cervix, what happens is that the cells are going to coagulate. In the normal cells, metabolism is not much. So meaning that when we shine the light, what is essentially going to happen is that we are going to see those blood vessels beneath. As a result, the cervix is going to appear pink. But in a situation where there is coagulation because of metabolism, the light is going to reflect back to us. And because of the reflection, we are going to see what we are seeing in the picture, which is acetal white lesion. It's quite different from HPV test. If you look at HPV test, first of all, it is a very accurate test, at the same time, a very effective test, which is reproducible. Very different from VIA. And it is very sensitive with high specificity. So that's why even the world is moving towards using HPV. Zambia has adopted HPV as a primary screening test. We shall be using it alongside VIA. So when you are looking at HPV, it can be self-collection or provider collection. And it's a very easy thing. So the other picture is trying to bring to our attention how the sample can be collected by the provider. We talked about cytology. In cytology, we mentioned two things. We mentioned the conventional part, and we also talked about the pap smear. And then with regard to this, cells are scraped from the cervix and they are then examined under the microscope.
So network, we have our fourth and final poll question for the day. It says secondary cervical cancer prevention focuses on the following except secondary cervical cancer prevention focuses on the following except A, screening, B, treatment, C, vaccination. I'll repeat the question. Secondary cervical cancer prevention focuses on the following except A, screening, B, treatment, C, vaccination. So dear network, I'll give it a few seconds for the network to participate in this poll question. We can see quite interesting voting patterns already. And while voting is happening, allow me to just encourage the network to ask your questions through the chat. And when the didactic presentation is done, we are going to go through your questions and discuss further. So a few more seconds to allow more people to participate. I also would like to encourage and invite everyone on the network to register your attendance by filling in the online form that's being shared in the chat repeatedly. All right, so I will end the poll now and share the results. So we had quite an interesting voting pattern where majority of the participants who responded thought C, vaccination, was the correct answer. And we had 34% thinking treatment was the correct answer, and the remainder thought screening was the correct answer. Dr. Kamfwa, please take us through this.
Thank you so much. If you were to be asked, can we prevent cervical cancer? Yes. Cervical cancer is a purely preventable disease. Can cervical cancer be cured? Yes. Cervical cancer can be cured as long as you have diagnosed it in the early stage. Can we eliminate cervical cancer? Yes. Cervical cancer can be eliminated. And there is a strategy which we are going to discuss for the elimination of cervical cancer. Since we have said that cervical cancer can be prevented, we have got three pillars in the way we can prevent cervical cancer. The first is primary prevention. When we are saying primary prevention, what do we mean? We do not want a woman or a girl to get HPV. So when you don't want somebody to get HPV, you say this, whatever you are going to do will be primary prevention. How about secondary prevention? Secondary prevention is where somebody has got HPV and you don't want them to develop into cervical cancer. And one thing that we do is the same thing which we say screening. Then the last thing is, here is a woman who has developed cervical cancer, but we want to treat or manage the cervical cancer. Then that becomes tertiary prevention. If you look at that organogram, look at it. So let's start with primary prevention. Primary prevention, even here in Zambia, we are actively doing it. By what? By means of vaccination. We have been vaccinating our girls who are below 15 years old. They receive 2 doses. So when you look at vaccination, it's the single most important thing in primary prevention. Other things that we can do is ensuring that people get IECs on how they can prevent cervical cancer, also male circumcision and condom use. So this is what we call primary prevention. How about secondary prevention? We said for secondary prevention, the most important thing is screening. And an example of screening is what we talked about, using VIA, using HPV DNA, or using cytology. So whenever you are doing screening, it means you have embarked on secondary prevention. And the last part of prevention is tertiary prevention. So tertiary prevention, what did we say? Surgery. if somebody comes with early cervical cancer, we operate and we call it surgical cure, where somebody is not even going to receive radiotherapy or chemotherapy. However, if they come with a slightly advanced invasive cancer, then we are going to give them radiotherapy or chemotherapy. And in a situation where it is completely advanced, it is not curable, then we can do palliative. So these three pillars, they are quite important in the prevention of cervical cancer. So what have we learned this afternoon? We need to appreciate that our focus is mostly on the women who are living with HIV/AIDS. Why? It's because these women living with HIV/AIDS, they are 5 to 6 times at risk of developing cervical cancer. Then what have we appreciated again this afternoon? We have appreciated saying that even if we have got various platforms for cervical cancer screening, the most sensitive, the most effective, accurate, and specific test that we should be using is HPV DNA. And Zambia has adopted this. In September last year, we started the rolling out. Again, what have we appreciated? We have appreciated saying we have got 3 pillars that we can use for preventing of cervical cancer: primary prevention, which is mostly vaccination; secondary prevention, screening; and tertiary prevention, the treatment. And that's why WHO has put the targets of 90, 70, 90 strategy, in which we want to vaccinate 90% of our girls, and we want to screen 70% of our women, and we want to treat 90% of our women. So when we embark on this, by 2030, we expect to reduce the cervical cancer. Remember, we are standing at 65.5 per 100,000. During that time, we shall reduce to 4 per 100,000. Thank you so much for listening.
Thank you so much, Dr. Kamfwa, for taking us through today's didactic presentation. And you will all agree with me that it has been a very, very informative session. But before we get into the next segment of our session, allow me to invite the network that may have questions or points of clarification on the subject for today to ask their questions. You can put them in the chat or raise your hand, and I'll be sure to pick you to speak. Are there any questions or comments? While people are raising their hands, there are a few questions in the chat box, Dr. Kamfwa. There's an interesting question here saying, after testing using HPV swabs, in brackets DNA, and the test comes out positive, what's the treatment to prevent the virus from causing lesions and getting established? Would you like to speak to that?
Yes. So when somebody has done the HPV and it comes out positive, what are we going to do? So what we are going to do is that we allow this woman to go under what we call VIA or VAT, now assessment, to look at the lesion. So this lesion, there are 2 ways that we need to treat it. Remember, we are not treating HPV, we are treating the lesion. So what we can do is, we can either destroy this lesion by freezing it or by using the heat, meaning that we can either use cryotherapy or thermocoagulation. But in a situation where we see this lesion is bigger, it is beyond where we require to freeze or to use heat, then we excise it in a method which we call large loop excision of the transformation zone.
All right, thank you so much, Dr. Kamfwa. There's a hand from the participant, Cholwe Muna. Kindly unmute yourself and ask your question, and we have Dr. Kamfwa and other subject matter experts on the call who will be able to attend to our questions. Muna? Muna, are you able to unmute? Okay, while Muna is trying to unmute, there's a question saying, explain, doctor, on how the Zambian situation is going to use the HPV alongside the VIA. Give parameters on how to do this. Maybe I can throw this question to Dr. Fundafunda to give his thoughts, and then also ask Dr. Chaila to also give his thoughts.
Maybe Chaila starts.
All right, I've been guided that Dr. Chaila is best placed to start. Dr. Chaila?
Yeah, yeah, thank you very much. Please kindly repeat the question.
All right, the question is, kindly explain how the Zambian situation is going to use HPV alongside the VIA.
Okay. Yeah, so thank you very much. As Dr. Kamfwa said, we are adopting, or we have already adopted as a country, the use of HPV testing as the primary method. This is with regards to cervical cancer elimination. Dr. Kamfwa did allude to the issue of primary, secondary, and tertiary prevention. And he did mention about the strategy. Probably we'll discuss it in future slides. This strategy is where we have to make sure that 90% of our girls are vaccinated by the age of 15. Then 70% of our women are screened for cervical cancer with a high precision test, which is HPV testing in this case. So how are we going to ensure? We have started, initially when we started HPV testing in 2019, the focus was only in Lusaka. Then we moved to Western and the Copperbelt province, then Central and Northwestern provinces, and now it has been implemented in all the 10 provinces of the country. So how is it working? So when women come to the facility, they are offered an option of HPV or VIA. Those that opt for VIA, which is a point of care test, they are screened there and then, and treatment is provided as required. Then when we come to HPV, currently we're only running it at the PCR labs where we collect the sample, then we give them an appointment when they should come back for their results. On average, as at now, it is taking about 2 weeks before the results are given. However, in Eastern Province, we are implementing HPV testing on the gene expert. So they have, the women are at some kind of point of care testing. So now, coming to the way forward, as we implement on high throughput machines, HPV testing, which primarily requires the healthcare workers to support the collection of these samples, either the patients collect on their own, or the clinicians or the nurses collect on their behalf, then it is sent to the lab. So very soon, we'll see a shift towards the HPV testing on the gene expert, especially in rural provinces, because we know that a woman may walk up to 10 kilometers or 5 kilometers before they reach the health facility. And you don't want such a woman to come back. Instead, in the rural places, we are going to focus on the use of the gene expert. We're expecting cartridges on the gene expert from WHO this year. And also we have, during our quantification, we indicated that we needed about 20,000 cartridges in the next funding season under PEPFAR. So we see that this is how we foresee the situation is going to go. But as at now, these two tests are running in parallel. Thank you.
Thank you so much, Dr. Chaila. There was a hand initially from Muna, and I acknowledge that you were unable to unmute, but please try again now. We've enabled you to do so. Muna, thereafter we'll have a comment or a question.
Thank you so much. Thank you so much. So my question is, I'm asking the doc, if we test, we use the HPV test to screen the women, and then the test comes out positive. Then we do a VIA, the test comes out negative. So my question is, what do we do? What should be our follow-up? Or what's the interval of those follow-up for the client, or how do we manage that client? Thank you.
All right, thanks for that question, Donize. I would like to throw that question to Dr. Fundafunda. Dr. Fundafunda, would you like to speak to that?
So you are saying that you do HPV test and it's positive, then VIA is negative?
Yes, doc. Yes, yes.
Okay, so maybe most people can take care of the HPV.
All right, we are struggling to hear you, Dr. Fundafunda. There's a bit of background noise on your end. But while we try to correct that, allow me to ask Dr. Kamfwa to speak to that question.
Thank you so much for that question. And very soon, you will receive the guidelines. The guidelines are going to be helping you, especially when you have got HPV positive and you triage, it comes out as VIA negative. There is no lesion. So in the guidelines, the next thing that you need to talk about is, for you to say VIA is negative, what is the type of transformation zone? Is it transformation zone type 1, type 2, or type 3? It could be that this woman has got a type 3 transformation zone. That's the reason why you have said VIA is negative. But remember, this woman has got HPV, which is positive. So in that situation, if we find that it is type 1 transformation zone, then 4 biopsies are going to be done, and then you ablate the cervix. So that's how it is going to be. We shall soon disseminate the guidelines which are going to help you.
Thank you so much, Dr. Kamfwa. I have one quick question from the participants saying, how available is the HPV test, and who should or who can do the test? Maybe I could throw this question to Dr. Kaunga. I see you've joined us. Dr. Kaunga, able to speak to that?
Yes. Good afternoon. And of course, the plan is that every woman eligible for cervical cancer screening should go through the primary test, which is HPV DNA test. But at the moment, we have been concentrating on the women at more risk. That's the HIV positive women who have been going mainly, if you look at most of the other operating or supporting partners like CIDAS and others, including, I think, CDC, we have been commonly triaging towards HIV, women living with the HIV. But all in all, it's, I'm sure the program desires that every woman go through the HPV test, knowing those advantages as the primary screening tool. Thank you.
Thank you so much, Dr. Kaunga. There are 2 questions that I'll read out now, and then we will have quick responses from Dr. Kamfwa. Then we'll move to the case presentation. The first one came from Lieutenant Colonel S. Tembo, who asked, what is the recommendation by MoH on the use of the camera versus not using it? That's question 1. And the next one is to come from Donize. Donize, you had your hand up. Maybe you could quickly ask your question.
I go ahead.
Please go ahead.
Okay, because I'm in a noise. Yes. We know that initial screening of this cervical cancer screening was barely visual, meaning without an aided eye. But we know that the sensitivity of the naked eye may not be the same as when we include the DC, digital cervicograph. So we know that the naked eye may be just sensitive to up to about 70% compared to when the camera is instituted going up to 85%. So really, the missed out cases are tremendously reduced when we use the camera. So in short, we are saying the camera will magnify those minute lesions which may not be well appreciated with the naked eye. And you know that when you use just the naked eye, you literally have no control. No other people would do quality control or some form of follow-up where you have pictures stored for future learning. So the camera really brings in a number of powerful attributes compared to just naked eye. It's like just a naked eye is just you see something passes, but how you are going to properly describe to others, it will be very, very subjective. But if the camera is here, we'll store the pictures and the other eyes will come and evaluate. Thank you so much.
Thank you so much, Dr. Kaunga, for that response. And it has really put into perspective the use of the camera during screening for cervical cancer. Now, dear network, we are running out of time, and I would like for us to move to the case presentation. Levi, I see your hand is up. I acknowledge it, but my sincere apologies that I have to now ask the case presenters from Kasama to take us through the discussion. And maybe if your question can be posted on the chat, one of the subject matter experts will attend to it. So allow me to invite our colleagues from Kasama, Dr. Majawiza, to take us through the case presentation for today. Doc, you can carry on when you are ready. I have a feeling you were struggling to unmute. Please try to unmute now.
Thank you so much, and good afternoon. Am I audible enough?
Good afternoon.
Yes, very audible. Please go ahead.
Okay. Presenting this case, Dr. Majawiza, representing Kasama General Hospital, Northern Province.
Please go ahead, Doc. We can hear you loud and clear, and we can see your screen. Dr. Majawiza, are you able to hear us? Dr. Majawiza?
Yes, I'm here. I'm having challenges moving the slides. I don't know what's the problem.
Okay, if you would like, we could share the slides from this end and you read through. Is that helpful?
It's okay.
All right, great. Kindly stop sharing and then we'll share the screen on this end. All right, dear network, as we are sharing the slides on this end, there was another question that came through. Someone asked to say, what type of vinegar should we use? Because in ShopRite or any other chain store, we have access to apple cider vinegar, the spirit vinegar, and different types of vinegar. Is there a specific one that we should use, Dr. Kamfwa?
3 to 5% concentration vinegar. The one with 3 to 5%, and where it hasn't been on the shelf for a longer period.
All right, thank you so much. I think we got that quite right. 3 to 5% vinegar or acetic acid. So we should not hear that people went and got concentrated acetic acid to apply on someone's cervix. That's going to burn them. So we have the slides now. Dr. Mazawiza, ready to go?
Exactly.
Great. Over to you.
Okay, so this is a brief history. So MK female 55 years old, para 5, about 10 years postmenopausal, and had her last delivery 20 years ago, presented with the following complaints: vaginal bleeding on and off for about a year, and passing blood stool and fecal incontinence for about 1 month. RVD, no history of hypertension, diabetes, or any surgery prior. Socioeconomic status: one of our granddaughters is studying.
Dr. Mazawiza, apologies for interrupting you, but we're seemingly getting a lapse in your audio. Do you mind changing devices, or can I read through these points as you are correcting the audio settings, and then for you to be available to respond to questions as they arise? We are really struggling to hear you.
Am I audible enough like this?
Yeah, you sound better. Let's see how it goes.
Okay, let me just restart the case. So the brief history of the patient: it's a female MK, 55 years old, para 5, about 10 years postmenopausal, and had her last delivery 20 years ago. So she presented with the following complaints: vaginal bleeding on and off for about a year, and passing blood stool and fecal incontinence for about a month. Her past medical history: she was RVD NR, no history of hypertension, diabetes, or surgery. Her socioeconomic status: she's a widow and stays with one of her daughters in Chisele. On physical examination, that of dated the 2nd of March 2022, the general condition: she was ill-looking but fully conscious. She was not pale. She was mildly pale, I mean, and she was not jaundiced or cyanosed. The ECOG status was graded to be 3. So the chest was clear. S1 and S2 were very normal. So abdominal findings was the abdomen was soft, non-tender, and no palpable organs. So vaginal examination revealed the vulva, which was soft with soft stool, multiple sores on both labia majora bilaterally, vaginal involvement, full thickness, with erect vaginal fistula of about 1 by 2 centimeter midway posteriorly. So the cervix was eroded with bilateral parametrial involvement, and it was very difficult to assess the pelvic side wall involvement. So per rectal examination, there was anorectal mucosal involvement. So what we did a cervical biopsy, and we suspected, our impression was suspected cervical cancer, clinical stage 4A. Maybe if you can move the slide. Okay, this is a slide showing what investigations we've done so far at our facility. These were done on the 1st March. So we did creatinine, which was, we did urea and creatinine. It's unfortunate we don't have reagents for creatinine, but urea was at 3.6. We did a hemogram, which revealed an HB of 8.8 grams per deciliter. Of note, our patient was RVDNR as earlier elaborated. We did also an ultrasound, which was essentially non-revealing. Yes. So that marks the end of our presentation. Looking at this presentation, we had these three major questions to ask regarding our patient. So the first question was, is it important to do valve biopsy in this patient? What involvement of the vulva? The second question was, how can we manage this patient while waiting for biopsy results? And the third question was, can this patient benefit from chemoradiotherapy? Thank you so much.
Thank you, Dr. Matawiza, for taking us through this case, a very interesting case coming from Kasama, the northern part of the country. So at this point, allow me to ask the network if you have any clarifications or any questions you'd like to ask the team managing this patient to go ahead and ask before we get into the discussion. Any points of clarification?
Yes. Sorry, Chair.
Yes. Please go ahead.
I didn't get the part, some part of network problem. Was there a valve lesion?
Yes, there was valvular lesion that was seen on examination.
Okay. I wished they didn't do any pics and pictures for the valve.
Dr. Mazawiza, do you have any pictures?
Sorry, we didn't take any pictures of the valve on this patient. Yeah.
All right, thank you.
Thank you so much. Are there any other questions? I see there's a hand from Levi Chifwaila. Is that related to the case? You can go ahead and ask.
Thank you very much, Chair. I just want to find out on the diagnosis made on the client. I heard something like a cervical cancer stage 4. I just want to seek clarification on that one.
Thank you so much. Very important question. Kasama team, any reason you thought it was stage 4A cervical cancer based on your findings?
Okay, if you look at our vaginal examinations, this is a patient 1 who has developed a rectovaginal fistula and oozing stupid vagina, and the whole thickness, is it the upper 2/3 of the vagina as well as the 1/3 of the vagina were also involved, and this is the lesions which were also even seen outside the vagina. So rectal examination finding also revealed anorectomucosal involvement. So if we put everything together, we graded clinically this patient to have 4A.
Thank you for your response. Thank you for your response. We are going to invite further questions, and I'll ask some of the subject matter experts to respond to some of the questions that are coming up. Any other questions regarding the case? Ethel, please go ahead and give us a question or contribution.
Thank you so much. I just wanted to find out if the Kasama team also performed HPV tests, because Kasama General is doing the HPV testing for screening of cervical cancer. Thank you so much.
Thank you so much, Ethel, for your question. Is there any additional questions as Team Kasama is responding to that question? Okay, Levi, I see your hand is up once more. Please go ahead and ask.
Yes, Chair. I just want to find out, was this the first contact that the patient was attended to at the facility? Because to me, she appears to be in a very advanced stage of the disease. So I just want to find out if this was the first contact the team had with the client. Thank you, Chair.
Thank you so much, Levi. Dr. Mazauza, there are two questions coming your way. The first one is, was HPV screening done in this patient from your facility? And the next one is what Levi has just asked, if this was the first contact at the health facility. Please provide more clarity.
Thank you so much, Chair, for the two questions. Maybe to start with the last question. This was the first time we had a contact with this patient. She came from very far, as far as Chisele. So this was the first time we had seen her. Concerning the HPV tests, yes, we're able to do HPV kits at the Kasama General. So on this patient, HPV tests, because looking at the presentation, she's a candidate who already have something we suspect to be a cancer.
All right, thank you so much.
So we just went ahead and did a biopsy.
Oh, great, great. Thank you so much for that feedback. I see there's a hand from Kabinga Charles. Please go ahead with your comment or question, then I'll transition to Dr. Fundafunda.
Yes, I wanted to know what was the management of the same case, the stage 4 of cervical cancer.
All right, thank you so much. So just to be clear, Charles, are you referring to this patient, what was done at Kasama General Hospital, or you would to know in general how stage 4 is managed?
Yes, what was done to the same case at Kasama General.
Okay, Dr. Mazauza.
Thank you so much, Chair, for that follow-up question. I guess the question is, how are we managing this patient at Kasama? So what we just did for this patient, we of course investigated her, and we gave her analgesics in looking at the HB. Started giving this patient hematinics. So basically, all we did for the patient is pain management as well as optimization of the hemoglobin as we await biopsy results. Thank you so much.
Great, thank you so much. Dr. Fundafunda, I saw your hand was up. Would you like to speak to some of the issues surrounding this case? And also we start speaking to the questions that Team Kasama had raised.
Good afternoon once more. I hope I'm audible.
You're very clear, Doc.
Thank you. So this is a very depressing situation with this lady. Clearly, this is a case that needs palliation. And as Dr. Kamfwa said earlier on in his presentation, cervical cancer is a cancer that is very, very preventable. And even when we screen, if we up our screening services, we should be able to pick out these mothers in a stage where we can treat them with surgery. Now, this is obviously palliative stage 4 or 3B going upwards, palliative care with a fistula. So ideally, I'm very impressed with the way Team Kasama has so far managed this patient, waking up the hemoglobin and looking at the symptoms, symptomatic treatment, which is palliation. So they are giving painkillers, which is ideal, and working on the HB. If possible, this is a patient that would need transfusion. So this patient would need to be referred to the cancer disease hospital with a confirmed diagnosis from histopathology, because Tim Kasama has already gotten a biopsy and now waiting for the results. So there is no need for HPV in this case when you have an obvious lesion. Remember, HPV, we are using it for screening. And when we find HPV with a cervix which is not obviously visible with a lesion, we would do biopsies, as Dr. Kamfwa said. But this patient is the one that already has a lesion like this. So they've gotten a biopsy and waiting for histopathology. Once we get confirmed histopathology, we refer this patient to CDH, where she will need further investigation, wake up for possible tumor spread. We'll need chest X-ray or CT scan of the chest and in the pelvis to see the disease spread. Thankfully, she seems not to have obstructed ureters. So, because the biggest killer for patients with cervical cancer is obstructed ureters, which will send them into uremic encephalopathy and those complications which come with uremia. So this patient will need to be sent to CDH, where she'll be put on palliative chemoradiation, not curative, because she already has a fistula, and this is not a patient that we're thinking of curing. We're just here at this stage, we're just trying to reduce the pain of this patient so that she can have a decent death. So we care for the relatives of this patient, care for the patient by counseling them on the disease extent and the expectations from this disease prognosis. So we need to also prepare the family on the prognosis, not giving them false hope, because at this stage, this is beyond cure, but just to manage the symptoms that come with the disease. Thank you.
Thank you so much, Dr. Fundafunda, for that comment. Before I go to Dr. Kamfwa, allow me to also invite Dr. Chaila to speak to some of the questions. There's a question that remains unanswered and on the importance of doing Volvo biopsy in this patient.
Yeah, so thank you very much for that question. Yeah, so remember, the reason when we screen a woman and we find something that looks like a cancer, we don't say it is cervical cancer. We always say query invasive cervical carcinoma. Why? It's not all cancers that you find on the cervix that will be cervical cancer. So it can be a cancer originating from somewhere else, and it progresses to go to the cervix, for example. Similarly, even for, now coming to our case, we can't assume that it was the cervical cancer that went to the vulva, for example. And correct me if I'm wrong, Dr. Kamfwa and Dr. Fundafunda, it is rare that cervical cancer actually spreads towards the vulva. So correcting a biopsy is just trying to know whether what we are seeing on the vulva, was it a primary vulva cancer or was it cervical cancer itself, for example. So yes, it was important to do a vulval biopsy because the cancer can metastatize to any parts of the body generally. So yes, it was important that we do that biopsy for the reasons stated. Thank you.
Thank you so much, Dr. Chaila, for that response. In a few minutes' time, I will ask Dr. Kamfwa to give us some overview remarks on the case management on this particular patient and also marrying it to what we have discussed in the didactic presentation. But before we get to that point, there's a question in the chat from Peter Singogo Police Clinic, and I'll throw this one to Dr. Kaunga. They are asking, could there be a way where we can refer a client to the cancer center without a biopsy confirmation looking at the clinical staging? So that is a very important question. Dr. Kaunga, would you like to speak to that? Okay, we seem to have lost Dr. Kaunga. I'll throw it to Dr. Fundafunda.
I hope I'm clear.
Yes, Doc.
Thank you. So when we send a patient to the cancer disease hospital without a histopathology confirmed disease, what we are essentially saying is that this patient will go and wait at the CDH before actual treatment starts being given, because the treatment is going to be based on the histopathology. Unless we are from even when we're coming from a health center, we have hospitals where this it's an anemic patient, anemia can be corrected from there, because we want the patient to be near the relatives. So that, family care is very important. When we refer a patient from far away from home, they are deprived of their family, that environment. So let's, by all means, try to send patients who have at least histopathology confirmed disease to the cancer disease hospital, even when even when we've clinically staged that it is advanced cancer, because even if it will be near the pathology, but it's likely to increase the time that the patient is going to be away from family without getting the actual treatment. Thank you.
Thank you so much. But before you mute Dr. Fundafunda, I'd like to ask you a question regarding palliative care. The team from Kasama did allude to the fact that they are doing their best to ensure that they take care of the pain requirements, or the pain medication was being administered to this patient. But in terms of taking care of the psychosocial aspects that come with a moribund condition like this one, are there any tips that you would give from your expert opinion to the team in Kasama for them to really help these patients' welfare?
I think we need to make it clear to the family, to explain to the family that even if it's in an advanced state, even if we're not assuring them of total cure, complete cure, we need to respect this client's life and give it, give her the most comfortable life that she can have before she dies. Because when we tell the family that this patient is not going to be cured, this thing is until she dies, some people give up and they will be start thinking of the distance from Kasama to Lusaka. But if it's going to give her the last 4 months or 6 months, if come life than if she didn't go to CDH, the family has to be explained to, so that even when they accept that she can be given a more comfortable end of life time, it was better that she comes to CDH just to improve the last few days. But even then, as we do that, we need to also prepare the family, counsel them. We need counselors in these areas so that the family is also prepared for the death. Thank you.
Thank you so much, Dr. Fundafunda. We have about 15 minutes until we wrap up. There's an interesting question that is in the chat that I would like to bring to the attention of everyone in case we didn't see it. There was a question from YK who was asking about testing men for human papilloma virus. And there was a response from Dr. Chaila. Maybe let me ask YK to ask his or her question, and we get feedback from Dr. Chaila. Thereafter, we are going to get to Dr. Kamfwa to summarize the case management and wrap up today's session. YK? Okay, YK asked to say, why don't we bring similar tests referring to the HPV DNA test? Why don't we bring them to the males since they are the carriers of HPV? That is a very, very interesting question. And Dr. Chaila did actually respond to this question, but maybe Dr. Chaila, for the benefit of those that didn't read the chat, you could just take us through the response to that question.
Yeah, thank you very much. Yeah, I thought it was a very interesting question as well. But I think the same question applies even now. We may ask the same question: why are we only focusing on girls when it comes to HPV vaccination? Yeah, so I think the main reason is we know in terms of, it's not only men who are carriers, even females are carriers of HPV. It's just dependent on who was exposed to the HPV first. So let's assume I have sex today with a woman that has HPV infection, and it's my first time, for example, having sex with that particular woman. It means the woman is the carrier in this case because they have been exposed to HPV before, and vice versa if it is the guy who was exposed to HPV. So both men and females are carriers for HPV. So HPV testing in men actually has very limited value. Really, for say, because if I test HPV positive today, what do I do with that information, or what will the clinician do with that information? We just say, oh, sir, you tested HPV positive. Maybe just consider getting yourself circumcised. Probably that would be the only value. But HPV testing is a relatively expensive test. We are probably spending about $30 to conduct one test, compared to VIA, where we're only spending about $5 at most when we factor in everything. So you see, it's so that information, when we have an HPV test, an HPV positive test in a man, may not really help us much. But when we bring it to our women folks, we know that that predisposes them to developing cervical cancer, and therefore we would want to invest more resources in that and make sure that they are treated adequately. And males, by virtue of the way our reproductive systems is arranged, we are more likely to clear the HPV infection faster compared to the women. One argument people may give is HPV can also cause cancer of the penis, for example, in men. But when we look at the statistics, we know that over 99.7% of all the cervical cancer cases are caused or associated with HPV infection. And therefore, that's why you want to put much of your efforts. But when we look at penile cancer, for example, it's only about 40–50%, that 25% actually, that is attached to cancer of the penis. But now when we even look at those numbers, they are very, very insignificant. So therefore, it will be a waste of resources to do HPV test in men now. And the focus really should to encourage the guys to go for VMMC. We have an easier way out of reducing the risks of us getting that HPV infection, and therefore that reduces the risk to our women folks, as that is by us infecting them with that. So it is not the best way to use resources because we will not do much with that information. And therefore encourage the guys to go for VMMC, and we leave HPV testing for the women because of the high burden of cervical cancer that they may have. Thank you.
Thank you so much, Dr. Chaila. As we wrap up our session for today, allow me to invite Dr. Kamfwa to take us through a summary of the case management regarding the case from Kasama. Thereafter, we'll get some few remarks from Laura after the summary. Dr. Kamfwa.
Thank you so much. Maybe for a start, if we look at HPV and women, as long as they are sexually active, at one time, they are going to pick up the HPV. 75%, as long as they are sexually active, they will pick up HPV. So meaning that if you look at HPV, when a woman comes who has got anal cancer, anorectal, our suspicion is HPV. When she comes with vulval cancer, I'll come and again speak to vulval cancer. When she comes with vulval cancer, the suspicion is HPV. When she comes with vaginal cancer, it's HPV. When she comes with cervical cancer, it's HPV. When she comes with oropharyngeal cancer, it's HPV. For a man, when they come with anorectal, it's HPV. Penile cancer, it's HPV. So if you look at HPV, it's the most common sexually transmitted infection. And yet there are these strategies that we can put across to make sure that we get rid of this. Now let's come to vulval cancer. When you look at vulval cancer, Ethel had to ask, was it prudent to do HPV in this woman? No, it wasn't prudent. Why are we saying like this? If you look at HPV, or if you look at vulval cancer, it has got bimodal distribution. In the young, the premenopausal, what causes vulval cancer? It's the HPV. But in the postmenopausal, what causes vulval cancer is skin dystrophy, such as lichen sclerosus. And when you look at this woman, she is 65 years old. So she is postmenopausal. So the chances of her getting this vulval cancer from HPV, it's not a thing, because we do not normally get vulval cancer in the postmenopausal because of HPV. If she was premenopausal, yes. So we do not want to waste the resource of doing HPV DNA in this woman. Even if maybe we were to do still HPV in this woman, for what? Remember, when we are doing HPV, the essence is we want either to see that there is a pre-cancer and we treat it, but already this woman now has got this cancer. So there is no need of us then subjecting her to HPV. Second, the Kasama people said that this was suspected stage 4A, correct? If you look at cervical cancer, it is the only cancer which we diagnose clinically. And if you look at what they said, there was already a fistula between the vagina and the rectum. If there is also a fistula between the bladder and the vagina, still it becomes stage 4. And the most important thing there, they said that the mucosa was involved. As long as the mucosa is involved, then there is a likelihood that the biopsy which is going to be done, and I believe they did, this is going to say that this is a stage 4. So for them to say clinically this is a stage 4B, they were right. But when you look at, again, this thing, was it necessary to do a biopsy on the vulva? Yes, it was necessary. Reason being is that we can have what we call two primaries. Two primaries. If you look at the lower third of the vagina and the vulva, they all come from the same cloacogenic origin, and they are all caused by the same HPV. So meaning that we can have a cancer which is on the vulva and another cancer which is on the cervix, and we can have what we call two primaries. And when we have got two primaries, the way we are going to manage this disease is slightly different. Then the question which was there was, what is it that Kasama is supposed to do before anything or before she's referred? The single most important thing is, because this woman has got a fistula and Kasama has got surgeons, the most important thing is you need now to start counseling this woman for colostomy. Start counseling this woman for colostomy, because it is not good she keeps on soiling her vagina with feces, because she'll be smelling. So what is more important is she requires what we call palliative colostomy as the first important thing, and she needs to be counseled about this. We understand that her HB is on the lower side, 8.8. So we need to optimize her HB. Apart from optimization of her HB, we also need to start giving her adequate analgesia. Pain control becomes the most important thing. Are we going to give her chemoradiotherapy? No, she's not going to get chemoradiotherapy as radical treatment. Get me? She's not going to get chemoradiotherapy as radical treatment, but she's going to get some radiotherapy and some chemotherapy. What type of radiotherapy is she going to get? Remember, the way we treat these patients who come to cancer diseases, when we are treating them for 5 weeks, we call it radical. Almost every day they are receiving radiotherapy. But this woman is just going to receive 2 types of radiotherapy, one day, and then she goes for a month without receiving another radiotherapy, which we normally say 10 gray. 10 gray is a very big shot of radiotherapy. Normally we just give 1.8. So she's going to receive some radiotherapy to palliate her, 1, with pain, 2, with the discharge. And of course, because she's having, again, soiling of this, she will also be on antibiotics, but of course not for a prolonged period. And she requires to be particularly on metronidazole. Metronidazole is going to be helping her to palliate that pain that she's having, to remove that foul-smelling discharge that she's having. And at the same time, it is also going to enhance the effects of radiotherapy. So what she's going to have ultimately is palliative care. So we shall palliate her using radiotherapy. And once we have given her 2 shots, like 1 shot per month, then the following shot, then we give her chemotherapy. And that chemotherapy, again, it's not for treatment. It's purely for palliation. That's why I said at the outset, saying, when you have got cervical cancer, which has advanced, remember, things are very bad. So that's why we want cervical cancer to be prevented and to be cured in the early stages. When we looked at screening, honestly takes only less than 5 minutes. But here is a woman now in Kasama who has to go through all these problems where she requires to be doing a lot of images to come to CDH. And even when we are doing this, we know we are not going to treat her, but we are doing what is called palliative. And that's why we urge almost all our women, please, 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 if you haven't been screened for cervical cancer, it's time you went for cervical cancer. As at now, around the world, every 2 minutes, we are losing 1 woman from cervical cancer. Every 2 minutes, we are losing 1 woman from cervical cancer. And this is not a very good thing. If you look at CDH last year, or maybe Zambia, we had 13,000 cases of cancers, 13,000 cases of cancers. You know, out of 13,000 cases of cancers, 3,000 were cervical cancer. And do you know how many women we lost who died? 1,900. So that's why we are urging you, please, please, please. This is important to screen. Get screened, get prevented. Thank you.
Thank you so much, Dr. Kamfwa. And clearly we can see the energy and affection that he attaches to the message of get screened, get tested, early treatment. So at this juncture, we've come to the end of our session today. But as mentioned, before we close the session, allow me to invite Mrs. Luatula, give us a few remarks, and then invite our guest also to give us a few remarks before we close the session for the day.
Good afternoon. Thank you very much. On behalf of the PIGO and indeed on behalf of HW21 Zambia, I would like to say thank you so much to HESA for funding the establishment of ECHO in Zambia. And also for CDC for the great guidance that we have enjoyed throughout the period. And then of course, UTH Hub and you, the network, for the great support, and also MoH for providing us with the environment in which ECHO has been able to thrive. As you are aware, we are a regional hub for COVID ECHO, and that's not a mean achievement. So I just want to say thank you very much to everyone. And I'll transition to Laura to give her remarks. Thank you.
Thank you. And I just wanted to say thank you for allowing me to be present at this session today. I have heard a lot about the ECHO platform in Zambia. I participated in the ECHO platform myself in the US as a nurse, but to actually see the platform in action was very exciting. And I'm so much looking forward to returning to Washington, DC and talking to my colleagues and others about the work that's being done here with ECHO, because what I'm seeing is not just a platform that allows so many providers. I mean, the number of providers alone that were listed as being in this session today, and then Lucino was sharing that there are other ECHOs going on at the same time with equal numbers. And then also to hear the expertise, both in the room, on the different phone lines, and at the different clinics throughout the country, to see that sharing of information and best practices is just incredibly powerful. And so I thank you for all of this work and these efforts, and especially this subject today. I mean, I myself learned a lot today hearing about cervical cancer screening and prevention and treatment. And it was such an important topic. And so I thank you for having this session, for allowing me to be present, and for all of the incredible work that you're doing. So thank you.
Thank you so much, Laura, for being with us and also for sharing these sentiments with us. And also thank you and your team for supporting the ECHO program to what it is now. And also like to thank all the ECHO teams across the country for taking part in today's session and participating as well as we have. And also a special appreciation goes to our subject matter experts led by Dr. Kamfwa. Dr. Chaila, we are really, really humbled by your timely contributions. Dr. Kaunga and Dr. Fundafunda, we really, really, really value your contribution to today's ECHO session. Dr. Kamfwa and your team, we look forward to the next session where you come and educate us more on cervical cancer and other subjects related to female sexual and reproductive health, so that we can better serve our people. So thank you so much to JPIGO and HW21 for pioneering the ECHO program, and also MoH for having been present to always provide the backbone for ECHO. So we really, really thank you for all your effort. And also not forgetting the IT teams, as we know this session is highly hinged on IT. So we really, really value your contribution and your assistance throughout the ECHO sessions we've had previously. At this juncture, allow me to thank all of you for having taken part in today's session. We are signing out.
Thank you. Bye.
Thank you very much.
Thank you.
Thank you so much.
Thank you so much for the presentation.